Every day, you essentially pay your dues by doing the harder thing when it's the right thing to do. Emily, it's good to see you again. How are you?
Good. How are you?
I am wonderful. I am just rolling along, just booking as many podcasts as I can in the last, couple of weeks, but excited to have you on again.
Great. Thank you so much for having me. I appreciate it.
I think I was looking through the episodes. Last time we talked about concussions, which is really nothing related to what we're talking about today, but
Yes, quite different, but still stuff
just
I
as
see.
important.
So that's good. It's
Yes.
nice because I get to do head to toe. The other day I saw like 6 knees in a row and I was like, oh, this is boring.
Yeah.
So I like
Yeah.
that. I like that I get the variety.
Yes. I have a new doctoral student, Courtney Camarales, who was a gymnast and is kind of like doing her last PT rotation. She wants to go into sports and gymnastics. And the baseball guys see like a lot of shoulders, a lot of elbows, a lot of knees, but ours is like our schedule is all over the place. It's like ACL, Achilles, elbow OCD, low back. I feel bad because in the first 2 weeks she got an absolute fire hose of information, but
Yeah,
it keeps it interesting.
it does. It does for sure.
And we want to talk about today, I think, something that I talked to Jan a few weeks ago. We talked about like Osgood slaughters and kind of like overuse knee stuff, which is great. But I feel like growth plates in general are kind of the macro thing where I feel like a lot of people, I get a lot of questions about like the 10, 11, 12, 13 about like, what do we do? It's so frustrating. We're missing so much time. They're growing, if doctors say just don't do gymnastics and that's not a great option, so I feel like the macro conversation of growth plates might be a good place to start. And then specifically, we want to talk about probably like what I think is the hardest one to deal with, the gnarliest one, which is like a hamstring type growth plate. So yeah, that's where I wanted to steer the conversation if you're okay with that.
Yeah, that sounds great.
So let's start then on the big picture, which is let's go with what are the main drivers of growth plate issues in gymnastics? So like, why are we having so many kids that deal with the Severs, the Osgood slaughters, the hamstring growth plate, the gymnast wrist, right? Which these are all just like global growth plate issues. So let's just start there.
Yeah. So that's, kids are different than adults. I think that's the first thing we have to realize. And we have to recognize that kids have different injuries than adults and their bodies are like their physiology and anatomy are different. So kids have growth plates and those are the weak link in the chain. So I always tell people for like Osgood slaughters, for example, if we go and try to do gymnastics for 20 hours a week, our patellar tendon's going to hurt. Whereas kids, their growth plate is that weak link. And so instead of getting tendonitis, they get apophysitis or irritation of the growth plate. Same with gymnast wrists. And so when kids are going through those growth spurts, they're just more prone to having these injuries because their bodies are just trying to catch up and it's just a physiologic problem that happens. And I guess it's not really even a problem. It's just something that happens and we just have to then try to figure out how to work around it. So when they are going through those growth spurts, like taking a step back and limiting numbers, I think is really key.
Got it. Yeah. So to kind of summarize people, it's a combination of growth. It's a combination of that is the weaker point, that growth plate. But then also we have, a really high force sport with high repetitions at an age, unfortunately, where they're definitely more predisposed to some of the crankiness. So it's this weird mixture of the sport is hard, the growth is happening, and we have these possibly really vulnerable growth plates, right? That is the apophysis would be the inflammation of the growth plate. Is kind of what apophysitis is, the lay term.
Exactly. Yep. So there's two types of growth plates too. I think we have to kind of back up and think about that. So an apophysis is a growth plate that doesn't necessarily like give you height, like in your leg, but it's where a muscle then has a tendon that attaches to that growth plate. And then your growth plates that give you like length, more like your distal radius or in your knee. Those are called physis.
Right.
So it's just a little bit different, but kind of similar issues can arise at both places. But yeah, like you said, it's kind of the perfect storm. Like you have all of those things happening in these growing athletes, and it's usually at a time when they're trying to, bump up levels and they're increasing their hours right when they're growing. And so I think just being aware that this is a time, and I see kids, it's funny, like I'll see kids around like 10, 11, and then I see them boom, like every 6 months to a year for like 2 years. And then they are finished growing or like they slow down growing. And then I don't see them anymore. At least I don't know where they go. Hopefully they're just better.
Yeah.
But yeah, that growth spurt time, it's hard.
Yeah. Okay. And so it's definitely the pulling on that growth plate is what we see a lot with like the quad and the heel and stuff like that. And we'll talk about the hamstring. So, and just for parents and for coaches that maybe don't have a medical background, the the type of bone that is in the growth plate is a less mature, it's more spongy, correct? I don't want to get this wrong, but my interpretation of what the literature says is that it's just not, and it's not fully filled in. So it's not able to handle really hard forces like a fully mature, long bone would, which you can take obviously a lot of impact. A growth plate where this pension is happening is not that really hard formed bone, right?
Yep, it's just a weaker spot. And so again, that's why they're more prone to having issues there. So another example of that is if you or I, Dave, we roll our ankle, like we stepped off a curb, roll our ankle, we're going to sprain our ankle.
Which I literally did yesterday,
are more
by the
like,
way.
oh no.
Yeah, I was running, but go on.
You're okay. Whereas kids are more likely to injure that growth plate that's in that same spot on the outside of their ankle. Now they may get a sprain as well, but they can get a little fracture there as well.
Okay, cool. Yeah. And so we'll kind of get through the medical stuff as quick as we can because it's not the most interesting for people, but apophysitis, right? Inflammation of this growth plate, right? We have, like you said, the physis itself can sometimes get a fracture. Where does a Salter-Harris fracture fall in this as well? Because sometimes I know that people are very confused by, Salter-Harris 1, 2, and all that kind of stuff. Like, is this an extension of overuse? Is this an accident? Where does that fall into play?
Yeah, so Salter-Harris is a classification for fractures that occur at the growth plate. So there's 1 through 5 essentially, and 1 and 2 are the most common. Those are the growth plates in the long bones. So they typically occur through an acute injury. So like I roll my ankle, or I fall on the ice and put my hand down, and then I break right at that growth plate. I think the one thing that's a little bit different is gymnast wrist. Because that is essentially more of an overuse growth plate injury, usually a Salter 1, right at the growth plate in the distal radius in the wrist. So Salter-Harris, I think for your medical people, we should know the different classifications because it can change management.
Right.
Salter 1 and 2, typically immobilization with a cast or a brace. But if it involves the joint space, which is a 3 and a 4, those tend to either need surgery or just really close monitoring.
Yeah. And that's actually a phenomenal way to kind of keep this conversation going, which is, in my opinion, this is maybe a little bit later in the conversation, but in my opinion, I feel like, unfortunately, maybe it's gymnastics, maybe it's youth culture, maybe it's just, trying to make sure you're not panicking too much when something happens. Sometimes I see the start of growth plate issues, whether it's gymnast wrist or hamstring or Osgood Schlatter, kind of get written off as like, oh, your wrists are just sore, or it's just growing pains, or, you just pulled your hamstring, you just tweaked your hip flexor. I see that a lot in like the lesser trochanter issues we have. And I think people in good intention, I hope, just so like, oh, it's okay, like we'll work through it. But then unfortunately they keep training to it, like Severs all the time. They're all just like, oh, just like, just walk it off, you'll be okay. But it can get really, really bad really fast. And so can you explain maybe why there's a higher risk of growth plate injuries becoming a little more tough to deal with, and why you should kind of have your ears perked up right away when someone starts saying that,
Yeah. So I would say, first, if a kid has pain, right? Like if it's like, oh, I just had pain for like 5 seconds, we don't need to freak out. But if it is becoming every day at practice for a week or 2 weeks, they're complaining of pain, kind of nipping that in the bud is going to make for a faster recovery down the road. So if you ignore Severs for 6 months, then it is going to take a long time, and they may to go in a boot for a little bit. So really paying attention and making sure kids are being honest and not just writing it off, I think is important, so that the recovery is faster. Same thing with gymnast wrists. I've had kids, they come in and their x-rays look pretty good, but it seems like gymnast wrists, they're back in a month. But then I've had kids ignore it, and then I'm casting them for 6 weeks and then a brace for another 6 weeks. And it's a longer recovery. So yeah, it's just important not to write it off.
And again, not to spook anybody, but the growth plate irritations can become stress reactions, which can become stress fractures, which, like you said, if left for a long time, the rarer case, but they can require surgery to get better with a pain or something like that. I've seen some cases where people have to get rods and screws put in. Obviously that's like, over 6 months to a year of your career that's kind of gone there. So the faster you can deal with it, although frustrating, and the easier you can kind of see, okay, why is this happening? What do we have to do? And man, patience is really part of it. Like I hate to break it to parents and people, like, listen, you're 10, you're 12, you're trying to do gymnastics or whatever. And in a lot of cases, you're trying to do elite gymnastics, trying to do level 9, level 10, like you're trying to do crazy hard skills, and you don't have full development yet. You don't have muscles to protect you. So it's just go slow, be patient, don't compete all the meets, all the hard skills, but like this might take you a year to grow and get your growth plates to close and feel better. Does that make sense?
Yeah, exactly. And I think, I think parents sometimes get that tunnel vision, like, cause they're at the gym every day and the kids at the tip, and they're like, I have to compete. I got to get these skills. But then and I feel like that's my job sometimes is like, okay, let's step back and take a look at the bigger picture of like, what is your goal this year? What's your long-term goal with gymnastics or whatever sport it is? And how can we make sure that you achieve that? So like this, little dual meet this weekend, that's not a huge priority, but your state meet in 2 months, that's the priority, right? So let's figure out how we can get you there for that.
Yes. And I can't even agree more, especially on the PT rehab side, is having the exact same conversation. I just had this with a level 10 who's doing elite, and she has like a medial medial like femoral condyle growth plate irritation. Not the end of the world. She can still train bars. She's still in great, but it's like, you're 12, it's January or February, and you have a very long, honestly, probably 10 more years of high level gymnastics because you're just really talented. Like, do you really think these 2 meets at the beginning of the year matter compared to 1 states, regionals, nationals, 2 elite meets in the summer, and 3 the other 10 years of your career? And once and thankfully her coach is amazing and really understands it. But like when me and her coach and all that had that conversation, we're like, oh yeah, let's just go really slow and let this heal. And if we come back in March or April and just get the states or get whatever, like we'd rather be ready for the summer, right? And I think when you can take a step back like that, you're like, oh, okay, this makes a little bit more sense.
Right. Exactly.
And then the last piece I want to talk about kind of on the macro before we talk specifically about hamstrings is I think people maybe sometimes don't understand how there's different ages or timelines for when certain growth plates close. And it's the reason why maybe like growth plate in the heel will go away first, but then you'll still be stuck with this hamstring thing, which is like, possibly months that it's really not making progress and you're just like so frustrated. So can you just talk a little bit about like the order of closure and what ages and stuff like that generally?
Yeah. Yes. Yeah. So that is a very important point, is that the growth plates appear and disappear at different times. So a really good example of this is the elbow. There are like 6 growth plates in the elbow. They show up at different times and they close at different times. And so a lot of times we actually have to, like, if we're worried about, is this a fracture? Is this just pain? We compare sides. So that's the nice thing about our bodies, is we have most of us, of everything that we can compare. But like in your heel and in your foot, so Severs, for example, that tends to happen on average like 10 to 13-year-olds, because that's when that growth plate gets really irritated. And then kind of moving up the chain, actually up your leg. So I'm going to mostly focus on lower extremity. The growth plates get irritated at like slightly older times. So I usually think about foot happening first, then the knee, usually like our 11 to 14-year-olds. And it's different a little bit with boys than girls too.
Yeah.
Girls tend to get it a little bit younger on average because they tend to go through puberty before boys. Gymnasts sometimes hit puberty a little bit later, depending. So it may just be variable. And then moving up to the hip, those actually can happen more in our high school age kids. So 14 to 18, we'll see those there. So knee, middle school, foot, more elementary school.
Yeah, and I completely agree that's pretty much what fits the clinical presentation I see, which is I see a lot of 9, 10, 11, 12-year-olds for Sever's disease. I see a lot of like 12 to 14-year-olds for Osgood Schlatters and Syndon Larson Johansson, which is just another growth plate, which 3 doctors all wanted credit for in the knee.
Yep.
And then the older one, which is really tough, which is like the 14, 15, 16 is when we see these really bad hamstring issues. And that's what we'll talk about for the rest of the podcast. But that's the hardest. And I think another compounding factor of why it's the hardest is for that age group, 14, 15, 16, you've either been patient and waited until puberty and you've kind of gotten yourself into a level where you're really competitive, or that like 14, 15, 16, 17 is prime time wanting to get to level 9, get to level 10, go to college, try to do elite. And so I understand people's frustration, but that growth plate is enormously vulnerable during those years where you're trying to do, and you're probably doing like 20 hours or so per week of repetitive motions. And so, yeah, I think it's hard, but you have to realize that like that's prime time for something to go sideways,
Yes. Yep. I think the other thing that's really tricky about the pelvis apophysis is more in the foot and the knee. They will get apophysitis, but usually I tell them like, hey, if your pain's minimal and you can do everything, you're not limping, changing your mechanics, it's usually very safe to keep going. But in the pelvis and in the hip, you tend to get these avulsion fractures, which we're going to talk about here in a minute. And so really not ignoring the hip pain and not working through it is really, really important for these athletes, because otherwise then you take something that's just a little nagging thing, apophysitis, and turn it into a fracture. And now we're on crutches and really time off.
Okay. So, and then that makes sense. So what is the provocative factor here? Is it a certain skill? Is it a certain type of skill? Is it the same thing over and over again? Like in your mind, when people come to you, what are they saying is causing maybe some of these hamstring issues?
Yeah, so for hamstring, typically it's mostly things where their hip is flexed, so bent up towards their chest, and then their knee is extended. So think
Mm,
if you're a righty doing a split leap, right? Your right leg. So a lot of things in that position, and usually it's like the quick motion things. So maybe a stalder, right? Like dropping into that
mm,
stalder position may be painful, or a switch leap. But maybe even things just like sprinting. So those really explosive, quick movements. So a lot of gymnastics basically
yeah.
is what's painful.
Yeah, for sure. And that's why it's tougher. And so it's interesting because actually the literature on proximal hamstring tendinopathy talks about like the two bigger types of classifications we have are either extreme end ranges, right? Which is like the more aesthetic type person who has like really aggressive leg kicking range of motion,
Hmm.
or someone who's doing a very rapid kind of elongation to contraction. Like I think, eccentric overload is one term. Some people else call it like the amortization phase. But for those that are not familiar, essentially the elongation is one of the hardest things for a hamstring to do, but then also that rapid contraction, right, causes a lot of shearing forces on the tendon when you're older, but it goes to the growth plate when you're younger. And so you think about what is a switch leap, right? For example, is a switch leap is both of those things. It's a very rapid elongation, but then you have to quickly contract back down to the beam. And so that pulling from end
Hmm.
range to down is, I think, why so many people actually get it with switch leaps to start. Cause it's like one of the most provocative motions. But like to
Hmm.
your point, which is sprinting looks a lot like that too, right? And then snapping into a stalder looks a lot like that too. And all the other things, round offs, like the hurdle for a round off. And I think that's where it comes up, right? So many repetitive movements have those things.
Yep. Yep. And yeah, and it's not like you're just doing a couple of those in a day. You're doing hundreds and hundreds of them.
Yeah,
So
exactly. Yeah,
yeah.
and then I think my experience, because we're out of network, so people come right to us directly, is my experience is people kind of have some low level crankiness. I kind of pulled my hamstring. It was sore, but I didn't think any of it. And then I did a switch leap, or then I sprinted for vault, or then I landed awkwardly and like something like really like, ooh, this feels terrible. And then it really kind of triggered it. Is that your experience, or is there other presentations that you see?
I would say most of the time. So I just saw a kid yesterday with this who is a sprinter, and
Mhm.
he's like, I was sprinting, doing like 40-yard meter, and just felt a pop pain. So that was what he told me. And then I, dug a little bit, and I was like, was your hip hurting at all before this? And he's like, I mean, a little bit.
Yeah.
So they usually will have a little bit of hip pain beforehand, but it's not something that's stopping them. It's just like kind of a nagging thing. And so
Mm.
that's again, like in the knee and in the foot, it's usually, yeah, you can push through. It's not a big deal. But in the hip, we really need to be thoughtful and cautious about when we're pushing through it.
Sure. Yeah. And it is worth noting that, there are many situations where people are doing everything right. They're training normally, they're watching their volume, and simply it just happens, right? So I don't want to pin people like you're doing something wrong. It's like this is just
No,
the situation with young athletes in a really high force sport, whether it's sprinting or gymnastics or whatever. So yeah.
yeah, yeah. It's hard, right? Like,
It's so
sometimes,
frustrating.
yeah, because like sometimes you're like, oh yeah, 2020 hindsight, maybe I should have backed off, but like I
Mhm.
didn't really think about it, or yeah, maybe I was a little tired that day, but like also you can't just like back off every time you're a little tired, right? So it is hard, and yeah, people aren't usually doing something significantly bad, but
Yeah.
just being thoughtful about it.
Sure. Yeah. Okay. And then so next, I think the bridge is to maybe pull up a couple graphics here of the hamstrings and then the
Yeah.
growth plates imaging we have, and that I think will help set the stage to really solidify, what is happening when someone has a growth plate hamstring issue, and then what
Yeah.
we're going to do to try to help out with that. So I will pull up the first, just the picture here, but can you just kind of walk
Okay.
through for the listeners what we see on the picture, and then I'll switch over to the
Yeah.
MRI stuff.
Yeah, so this is the back of someone's leg. So your hamstrings are made up of three muscles. And so going from like the inside to the outside, they're called the semimembranosus, the semitendinosus, and then the biceps femoris. It's not super important, but just know that there's three pieces. They start up on, it's called your ischial tuberosity, which is at your pelvis. So that's your sit bones, and then they go all the way down to the back of your knee. So that's an abnormal looking ischial tuberosity there on the
Yeah,
right.
I was trying to look at this one over here. I was trying to point for the listeners. There's this side which is
Yeah, okay,
not
there we go. Yeah, yeah. So on
is
the
fully
right,
attached.
sorry. Yes. on our right, the like looker's right, that is a normal looking ischial tuberosity, or what we call, lay people call the sit bones or sits bone. And so, when you're sitting on your butt, you can probably feel those, but that's where the hamstrings start. And what we tend to see is, again, like they may have a little pain up in their hamstrings up kind of high. And then they have that one big pop. They do something explosive or quick, and then they pull, the hamstrings are just so strong that it pulls off that bottom piece of the ischial tuberosity. This is like a really impressive
we found
looking
like
one.
the gnarliest one.
Yeah.
I wanted to like make it obvious for someone who's watching, right?
Yes. Yep. Yeah. And so sometimes they won't look this obvious. And like on our x-rays, what we'll see is just, we'll see the little growth plate, and it just looks a little bit wider on one side versus the other, usually the side that hurts. And so that's why, like for medical people who are ordering x-rays, it's really important to get a pelvis and get both sides. Because I just had a kid the other day who had a hip injury, and they just got the one side. And, the radiologist is saying, maybe there's a fracture there. Well, the kid only hurt in the front of the hip. So like that wasn't it. But yeah, that's the pathophysiology, I guess, of it.
Yeah, that's great. And I think it's important to note that, again, this is like the extreme end of like a hamstring issue. Usually what happens in my experiences is that the pain starts and it starts to get, but they do have one event that causes like a significant increase in pain or some limping. And they're like, okay, something's wrong here. I have to get this checked out. They go to the doctor, get an x-ray, MRI, and it just shows like an increased signal, just a lot of inflammation around the growth plate. It doesn't show this detachment, which is the worst, situation here. So I think that's where most people in the bell curve fall, which is just like a really inflamed, irritable growth plate. This is like a very traumatic situation. But I would say, would you agree? Most people just fall in like the extremely cranky. Yeah.
Yeah. It's more like, hey, that's just some apophysitis. So that's that irritation growth plate, the Osgood Schlatters, the Severs. We just don't have any fancy names for the ones in the hip. So.
And people can see here, just one more picture. It's just a switch leaf here, and it points out all these things tying together, which is when this is a left-legged switch leaf. So when her left leg is in front, it's this hamstring in the back is pulling very hard on that same attachment point, which is right here. For those that are looking on the imaging, it's just like an ischial prominence. So that giant set of three muscles goes to one tendon, which goes to one bone where the growth plate is. And that really is kind of the catalyst here, which is just like you have a giant amount of force yanking on this growth plate, similar to like the quad and the knee. And you're doing so many things over and over that require stepping in for toe-ons or sprinting or leaps or jumps. And it's very easy to build up the workload volume on someone who is, younger and not developed, but also, oftentimes when long bones grow, the flexibility is already at its kind of outer limit of, because they're growing, the bone's growing faster than the muscles keep up with. So you already have some tension through the growth plate, and then you do switch leaps, then you do other stuff like that. And that's kind of where, this perfect storm comes up.
Yep.
Cool. Okay. So I think that makes sense. People probably halfway point of like, great, sounds awesome. What do I do? And so let's kind of just go through the phases of the very acute, maybe the intermediate, and I can obviously offer some rehab things along the way. But so someone comes to you and, is having this issue, what's the first, let's say imaging has confirmed that this is just a cranky growth plate. It's not fractured, but as a physician, what is the first thing that you feel like you need to help somebody get through to kind of get things to feel better?
Yeah. So, looking at their exam, and I think it's always important. If you go to a doctor who's not familiar with gymnasts or dancers, they're going to be like, oh, your hamstring flexibility is great. This is excellent. But really comparing side to side and then asking the athlete, like, do you feel like this is not like your stretch that you're feeling, or the tightness or the pain is more than it used to be? I think that's one thing. The second is, are you having pain just walking? So if you have just the apophysitis and you're like, hey, walking's fine, but it's more the gymnastics that hurts. We don't put them on crutches. But if they've had that avulsion fracture and they're having a lot of pain, doing some crutches really just to offload it, because you can't cast that fracture. That would be a little unpleasant. Going to the bathroom might be tricky. So, and then getting them into physical therapy, I think, is really, really key to figure out why did this happen? What are the like mechanics that essentially led to this, and then addressing the issues that are there. So, I'm not a physical therapist or an athletic trainer, so like I can't.
Well, I am,
say,
so I can share.
Exactly. And then say, figuring out, for me, I always want kids to go to the gym some, as long as they feel good going there. But figuring out what skills they can do, right? So you can go and do some like hollow body rocks. You can do push-ups, right? You can do some upper body stuff. Maybe you can even swing bars a little bit. so that you still feel like you're training and staying in shape, but really offloading that hamstring and giving it some time.
Yeah, absolutely. And I can definitely share some insights here from the people from someone who sees these people very early is for sure, without a doubt, you have to be very honest and open about like, listen, this is going to take 2 to 4 weeks to feel better. Like I know it's the middle of season and you have states coming up, but I hate to tell you that like, it's not going to feel better in a day. This is not like you tweaked a muscle and you're going to be okay. So setting, level setting expectations from a really early point is key for me. But with that, I tell them like, listen, there are so many things you can do. You can do core, you can do upper body, you can do strap bar if like you're not feeling too painful. But also too, is there's still so much stuff you can do around the hamstring as long as you're not doing switch leaps and jumping and running. And so that's kind of the preface. And the one thing I do think is really important to mention is for a lot of athletes who are growing and or just have natural tendencies, fixing someone's like very overextended posture or an anterior pelvic tilt is super important here because like we said, the hamstring's attached to the ischium, right? And so when you have someone who either has very stiff groin and hip flexor or quads and they're in a big arch, or they're just kind of a hypermobile person who rests on their over anterior pelvic tilt, that pretensions the hamstring and it pretensions the sciatic nerve, which goes right by the hamstring as well. So I do see a lot of people who have some notable pain because they're not aware of that very arched position when they run or when they jump or when they do switch leaps is causing some pretension on the hamstring. So this is a really great time to work on that, which is, can we do some stuff for your quads, your groin, your core to get you out of that posture of anterior tilt? And that alone, I think, helps to reduce some of the tension, along with little stuff like sit on the cushion and, sit on your sweatshirt at school instead of having to like sit on the hard chair, or try to make sure you don't sit for more than 20 minutes. Like all those little things usually help to put the fire out a little faster, along with heat and massage manual therapy, like all the things that you would do at PT, plus just some education,
Yeah. I think a couple of things you mentioned really resonated. First is setting the timeline expectation. And you're super nice because so if I tell gymnasts 2 to 4 weeks, they hear like, oh, one to 2 weeks, I feel like. And so
2 to 4 hours, right? 2 to 4 hours.
Yes, right. Like I'll be fine tomorrow. So I always tell them it's going to take a long time. And also the higher up the hamstring injury, the longer it takes. So like if you have a hamstring strain down by your knee, those usually actually improve relatively quickly. But a proximal hamstring injury and those apophysitis, if they're really flared up and they've been ignoring it for a while, that can take even a couple months. And so depending on how severe this is and what they're looking like, especially after they've rested for a couple of days, like if they've rested a couple of days and they're feeling great, that's usually a good sign. But if it's still bugging them after a week or so, that's a problem. And I was also reading, in preparation for this about like, what are the risk factors for this? So there's a couple of risk factors we can't control, right? So like I can't control. So the older you are, and if you've had a previous injury, I can't change that, right? Like that's just how you are. But having a previous hamstring injury or apophysitis in your ischial tuberosity does increase your risk for this. But like you said, the other things of like making sure you have good quad flexibility and hip flexor flexibility is really, really important. And then making sure you have good core and pelvis stability is really important. So like you said, addressing those early on. And then I think the other thing that's really important, especially in our gymnastics world to note, is that what is not a risk factor for this is weight and BMI. So having a higher weight and BMI is not a risk factor for this. So I just always want to emphasize that in our gymnasts.
Yeah, absolutely. And so we'll give this a theoretical for me too, which is like, so say you come in and you have your imaging. So for 2 to 4 weeks, you're probably just going to be laying low, chilling, doing a lot of bars, doing a lot of core, doing a lot of upper body, trying to do whatever you can to kind of get by. But in the clinic with us, like usually 2 weeks goes by and I'll tell someone very honestly, like, listen, you don't really need me right now, right? Like I can help you assess the core stuff and I can give you some exercises, but you don't need me to walk you through exercises because we're just letting it calm down, right? Which is different, which is if somebody's older and the growth plate is closed, say a 20-year-old, if I'm working with a college gymnast, they have a hamstring tendinopathy. We're trying to load and find that kind of wiggle room of like, okay, let's cause some discomfort to make it heal. In a growth plate injury, we're like, nah, we're backing off completely, right? We don't want to irritate that at all. And it usually, in my experience, takes 2 to 4 weeks for that to feel better, for them to get to a point where they're like, okay, it doesn't hurt to do basic things. And from there, I like adding in some extra direct glute and kind of hip work together to try to like load the area and like what we call like an isometric contraction, right? So like we don't want to really cause a lot of force to go through the growth plate, but we do have to start stimulating the growth plate and the hamstring tendon a little bit to see, one, if it's painful, and two, if we can tolerate more progressions. So like doing things like isolated glute bridge marches, just a double leg glute bridge hold, just to see if you feel anything. And a lot of times people 4 weeks out are feeling pretty good where they can tolerate some very basic stuff, along with like side plank clamshells, along with like lateral band walks, things that don't directly load the hamstring, but they're certainly working the area, right? They're getting the self involved. So if you get all the core stuff, dead bugs, bird dogs, side planks, along with some glute stuff, and then the other leg, you can probably get actually a pretty decent workout program. So I'll give that to somebody for like, here's this, I'll make a Google Doc, we'll go through it, make sure you do okay. But like, I'll see you every 2 weeks for a half hour, because nothing's going to speed up the healing timeline until we get to like the 8-week mark. You know what I mean? So that's from the physical therapy side. And I can pull up just a couple videos that I have for people, so that if you're just watching on YouTube, you'll see them. If you're listening on podcast, I'm sorry. But yeah, just, basic side plank clamshells, which again, don't directly load the hamstring, but they are very much important to, one, just keeping them active, but two is keeping someone out of that anterior pelvic tilt. You need a lot of like the rotation backwards, right? So that one, yeah. So just stuff like that is the first step. And then we'll share more. But is there anything else that you kind of feel like is helpful in like the first maybe 6 weeks of like, this stinks besides
No, I think
stuff? Yeah.
Yeah, just, again, I think setting up that like mindset of this is going to take a little bit is key, so that they don't get frustrated. But yeah, again, that's why I defer to you for what rehab exercises you're starting when. I think that's key.
Yep. Yeah. And I'll quickly fly through the middle of the section here, because people are probably curious about it. And then we'll come back to maybe the clearance and return. So yeah, so after somebody maybe like 8 weeks is tolerating this pretty well, I think it's important that people can realize that you can load the hip and the hamstring, but not do like hamstring curls, right? Which is really not tolerated well. So there's sometimes like compound movements like step ups and split squats, which kind of load the hamstring, but they kind of don't load the hamstring. So something like a regular split squat you're seeing here on screen, or a low box step up, or a single leg squat, those are very knee dominant, quad dominant exercises. And we can get somebody active without causing direct loading to the hamstring. So I would start with, that kind of stuff. I would start with very light soft tissue mobility work. And I would also try to start with just very basic progressions of, I'm trying to kill time so I can get to it. Where is it? Yeah. Very slow progressions of just directly loading, but eventually it is isolated hamstring curls. So it's just doing glute bridges, just doing literally ankle weight hamstring curls, because you just want to get stronger. My recommendation is every other day, so 3 days apart. So load the hamstring, give it 2 days for the growth plate to totally feel okay and monitor symptoms, and then 2 times a week load that. I think that really is the best way to go. I have success with single leg weighted hip lifts, single leg step ups, single leg split squats, and then eventually moving to things that are more directly hamstring loading, like single leg RDLs, or directly doing like a trap bar deadlift. And so I think it's important that people understand there's a lot of progressions we can do from the 8 to 12 week mark, which slowly get you stronger. And the last thing that I want to see somebody do, probably now looking at like 16 weeks after they've really been tolerating stuff well and they're cleared maybe to do some more, is to try to start doing some like eccentric overload type stuff like this. So like using your hands to take off percentage of your body weight and just doing some split sliders. If somebody can't do this, I can't pause the video without it, but if someone can't do this basic split slider, I'm not even having the conversation about gymnastics and sprinting and running and kicking, because that's all way more dynamic. You know what I mean? Yep. So yeah, just some exercises there. But my guess is that you probably see somebody back around like the 3-month mark or something like that. And so say they're feeling really good, PT is going really well. What's that conversation look like now?
Yeah. So, I always chat with them about like, what is PT doing? What are your exercises? How often are you doing them? Making sure that they're being compliant, and then, making sure that they're not having pain over that site. Depending on if they had an avulsion fracture or if it's more just apophysitis, if they're feeling good, I may or may not repeat x-rays, because what's more important to me is their clinical picture than what their x-rays may look like. And if they're feeling good and they're doing great in rehab, and then they're starting to do some eccentric strengthening, kind of what you were getting to there, then we talk about a return to play progression. And so, it's really important that you don't just say, okay, you can do a single leg glute bridge, go to gymnastics, right? Because otherwise you're going to see them back in another couple months, if not sooner. And so really making sure that they're doing a nice slow progression back into the gym. We do have a return to sport progression that I usually give my gymnasts. And so and that's published on current sports med reports. It's returning to sport after gymnastics injuries. So that's what I, give kids if they're with a PT who doesn't understand the sport as much as you do, Dave. But otherwise I let my PTs kind of take over and help them get back into the gym.
I will pull this article up. Aha. Yeah. So this is the
Yeah.
article that Emily was referring to. So yes, if you are someone who is maybe not as dorky like we are and you need some help here, Emily has a phenomenal article that she published 2018 this came out, right? Yeah. So definitely check this out because it has some very, very useful progressions. Yeah. And I think this is I don't know why the hamstring issue sticks out the most, but this is probably one of the biggest clear-cut examples, not that it shouldn't happen always, is that if you're a medical provider, you really want to try to get them as far as you can down the path of exercise and demand and difficulty. And then as a coach or a parent, you want to understand that you have to start like by catching them on the way in. You know what I mean? So like a medical provider hopefully is understanding we can do the eccentric stuff. We can do RDLs. We can do some jumping and some sprinting intervals to get somebody's hamstring ready. But then also too, like I wouldn't be afraid as, someone who knows kind of what's going on and other people is try some kicks, try some jumps, try some basic stuff that, is a kind of active flexibility type work. And you want to do the same dynamic type work that if you had a soccer player, you'd probably have them run 45 cuts. You'd probably have them run some sprinting on a woodway treadmill or something like that. In my mind, I want to expose somebody to that in the rehab setting before I feel comfortable letting them go back and really start gymnastics basics, because it's not that I think they're going to get hurt. It's because I know the coach on the other side is a little bit like, okay, like what can we do? What can we not do? Like that whole situation is overwhelming. So yeah, don't be afraid towards the end to try some banded kicks or to try some jumps or, have the athlete just like, say, go to the gym and just jump on the tumble track and just do some very light jumps and just tell me how that feels. Like, don't feel crazy, just 10 minutes. Just tell me how it feels just to jump and do some very basic flexibility type work like that, or have someone try a split. And it's probably not going to look great because they haven't done one in a while, but like you want to make sure someone's not having a lot of pain with that. You know what I mean?
Yep.
And
Yeah.
then,
Our PTs often have, sorry.
Go ahead. No, go ahead.
I was going to say, our PTs often have our gymnast videotape stuff if things are bugging them too, in the gym, so that then they can see, just because our PT gym doesn't have like all the equipment, obviously, that a gymnastics gym has.
Yeah, for sure. And then if you are someone who is a little bit more well-versed in gymnastics and you are a medical provider or stuff, I'll bring up a picture of what the programs that I make are. And so we would have somebody take their skills and we put them on what days. So if you're looking at this, you can see it, but if not listening, it's just the days of the week all spelled out Monday through Saturday. And then it has vault, bars, beam, floor. This is a female gymnast I made this for, obviously. And then on Monday through whatever, we have the days that they're in the gym and what events they're doing on the gym. And essentially I have taken their skills and I have put them into 5 of these, 5 of these, 5 of these. And there's days blocked off where they're not doing anything because they're not at gym. But essentially we have a guideline here of what skills are probably less problematic and what ones are probably more problematic. And we wouldn't put those until later. And so if you are someone who does, you did gymnastics, you did acro, you do understand a little bit about what this terminology is, ask them what their skills are, meet with their coach or talk with their coach on a Zoom call and literally just have a conference with the 4 of them. Like, okay, what skills do you want to get back to and what ones are not as hamstringy, right? Probably basic bar work and turn choreography, tumble track, all that kind of stuff. And you can go over the course of 6 weeks from softer surfaces like tumble track and tramp to harder surfaces, but you can also go from the basic skills that don't require your hamstring to the harder skills that do require your hamstring towards the end of 6 weeks. So this is obviously like the 201 grad level course of this, but like, if you're just barely hanging on, just use Emily's protocols. They're wonderful. But if you want to, like, if you have an elite you're working with, or if you have like a level 10 who's like really hardcore, you gotta get in the weeds a little bit. You gotta learn some skills,
Yes. Yeah. Yep.
Cool.
And then I think the other thing, Dave, I wanted to bring up is there's good evidence in ACL rehab, less in other body parts, of psychological readiness. So making sure the athlete is mentally ready. So especially if you have that kid who, hey, I was doing a switch leap and felt the pop, have an avulsion fracture, and now they're scared, right, to go back and do another switch leap. So one, can we not do that skill for a little while, right? Can you just do a split leap in your routine? Or you're like, no, I'm a level 10. I need my switch leap to get whatever credit. So making sure they're mentally ready to do that, because otherwise they are going to either injure that again or injure something else because they're not quite mentally ready. And that's a hard thing to ask, because again, I think a lot of our gymnasts are people pleasers and they want to do it and they're like, yeah, I'm totally ready. But are they actually mentally ready to do it?
Yeah, that's wonderful. And I think there's 2 important points here. One is that you want to understand that there are ways to slowly build up that confidence with the skill progression, right? So I see this a lot in the Achilles too, because people are like, do not want to jump, right? Of course they're terrified to jump.
Yeah.
But the first time they do plyos, they're like, like, you want me to jump over this hurdle? Like, but like a two-legged mini hop is very different than a single leg bounding repeat hop, right? So you can do that for the hamstring too, which is, the first time they do a single leg deadlift, they're probably a little nervous, but that gets comfortable over a week or two. And then you have them do some sort of a very slow kick, and then that gets comfortable over a week. Then you have them do sliders, and that gets comfortable over a week. You can look back on those 6 weeks and be like, listen, like some of the stuff you're doing in PT for sliders and kicks and active flexibility is arguably more force than this little jump I want you to try on the tumble track. And that kind of like starts to build some confidence. So on the ACL side, I think that Mike and Lenny, who I work with, are masters at giving the right dosage of jumping or running or cutting to build that confidence psychologically. And then it's a positive feedback loop. And I would encourage people to do the same thing. The other thing that's very helpful is on these programs, as you can see, we intentionally build in an event where they're not doing whatever running or whatever over here on Beam. We build that in on purpose because it intentionally lowers the volume down for their day. If they have 4 events they usually do, but one of them they're doing their home program, they're probably not going to be as worried. And that's also why we give these big days off in between, because we want someone to not get too sore throughout the week. So intentionally build in 24, 48-hour windows where if they do get a little sore, they realize like, oh, it went away in another day. I'm probably okay. I just had this, like, I'm just getting back to gymnastics and that's okay.
Exactly.
Cool. Okay. So last thing I think to talk about is, are there any tests that in your mind that you really want to see are good, like on imaging? Are there things you're looking for? Because I have a couple just like I said, strength tests I think that are important, but like some people are like, okay, how do I know when I'm good to fully go? Like when I'm like all set.
Yeah, it's hard, right? There is no one specific test that like this is the one thing everyone must do before you go do gymnastics. So like I said, I don't always repeat X-rays as long as clinically they're feeling good. MRI too is not always helpful for returning you. So MRI can be helpful, not so much for the bone, but if you're worried more about a hamstring tendinopathy, that tendon injury. So that can be helpful initially in figuring out kind of your timeline, like how significant the tendinopathy is. But it's not great at like determining, yep, you're ready to go. So we don't really repeat MRI. Same thing with ultrasound. Ultrasound's not all that helpful either. So for me, it's, hey, are you progressing in PT? Have you started the like more explosive sprinting things, the kicking things? And so that's where I often am saying, my job here is done. You're good. The PT is going to take it over from here.
Cool.
And then I think just the athlete being honest. And then the other thing I want to say about that is once your PT does say you can go do gymnastics and is progressing you, the risk of hamstring injuries reoccurring is pretty high. And so even when you're done with PT, I always emphasize you have to keep doing your home exercises. Even when you're like, I feel great. If you can do your home exercises 2 or 3 times a week, whatever your PT has given you to keep that hamstring, flexible and strong, and your pelvis and strong, I think is really important to try to prevent you from coming back to see me.
Nice. That's good. And I was just jotting down because I can fill in the gap here as well. I think for me, I look to the physician to be like, okay, am I really good to like push the needle hardcore? And I oftentimes will be like, yep, imaging looks good. Clinical looks good. I think we're ready to really hit the gas pedal here. And so in my mind, again, from the tendinopathy research, the 3 things that I want to see in someone who's going back is going to be the higher range of motion demand, right? The higher speed with lower force, and then the higher force with lower speed. So those 3 examples for me are, I want to see someone who can do a split comfortably, not like it's all the way down, but they're able to feel like I feel in the mid belly of my hamstring. I have no buttock pain, and they're able to do a 30-second, static hold or some more active work. That's really important to see. And then high speed, low load is just sprinting, right? So I want to see someone who can really open up a maybe like a 20-meter sprint. So a 10-meter acceleration, full on effort for 20 meters, and then slow yourself down for 10 meters. If someone can do a couple sets of those multiple times throughout the week, I feel though I'm really good with that like high speed, but kind of lower load. And then the lower speed with higher load is a slow tempo single leg RDL, right? A slow tempo front foot elevated split squat, a single leg physio ball curling. You want to see those athletes doing those really higher threshold movements, because in my mind, not that we have any, this is like a paper where they're like, what's the evidence for hamstring and gymnastics? Like nothing. Okay, now what do? We go to the clinical company. This is what I feel is that like after seeing a lot, I feel like those 3 things for me generally give me the buckets that gymnastics will encompass: the large range of motion, the high speed, and the really, really high load. And so I think those are kind of good back of the envelope things for providers to kind of think about.
Yeah. I think the other thing I always want to see is near symmetry, right? Like
Right.
a lot of gymnasts are not totally symmetrical, like especially
Yep.
if this is your non-dominant leg, your flexibility may not be as good in that side, but you should be 90% in your flexibility, like to the other side. And same thing, like, in clinic, an easy thing I often do with a lower extremity injury is a triple hop. And so if they,
Mhm.
can't triple hop 90% of what they can on their uninjured leg, they're not ready. So those are basic things that, like, if you're not a PT and you have like this little space, you go on the
Yeah.
hallway and that's about all you got. Those
Yeah.
are
And
those are
I
simple
would,
things that I do.
yeah, I would say too, like if you work in a PT clinic or an AT clinic, man, like fight tooth and nail to get a dynamometer. Like I know it's expensive. The Lafayette ones are $1,000 and Vald has a new one that's really great. But we like literally every single thing we can for quad and hamstring or shoulder and elbow. Like we're really trying to get good objective data. So if
Yeah.
someone comes to you 2 weeks out, don't use the Vald. Like that's not a good idea, right? But like if someone's 2 months out and they're like it's kind of hurting, it's kind of not, like try to do a sub maximal strength test and see what their actual force production is. And then at 6 months, you can have someone do a max effort. We, to share all the secrets, sorry, Mike and Lenny, we have a bolted down plyo box with a chain link attached to the wall so that it goes through the dynamometer. So it's completely zero tension. It's like taken out in the toe. So it's just straight U versus the machine. And we monitor quad and hamstring with a chain. And so that's a really good way to gather data. So yeah, if you don't have one, you should try to convince your boss to buy a dynamometer because it's the best tool you'll ever get to convince people like, okay, we have more work to do here, or, hey, you're doing great. This is awesome. You're actually really strong. You're within 5% symmetry of that hamstring on the other side. That's awesome. Like you're probably good to open it up for these sprints.
Yep.
Sounds good. Well, that is a lot of information. I'm sorry for those that are listening and wanted to know more, but about hamstring stuff. So I guess lastly is just when this episode comes out, the symposium recruiting will be in full swing. Everyone will know that it's open for access. So you're going to be talking on the first day, I think, about more of this kind of stuff on the medical side. So can you just kind of broad stroke share what's in the lecture and what will be exciting?
Yeah, so I'll be talking a lot of the same stuff, but even better, even
Down
more in
the
depth.
rabbit hole more.
Yeah, of hamstring and ischial tuberosity, apophysitis, and maybe touching on some of the other pelvic apophysites that you can get as well, and just growth plates and the physiology and all the nerdy medical stuff that we love.
That's great. I'm actually very excited. Like, not that I'm not excited for the whole weekend, but the medical day, man, is super good on like the current, not controversial, the current hot topics that we're all dealing with. So Ellen and I are talking about Achilles issues. I'm talking about elbow OCD surgeries, which our paper is in submission now. And then you're talking about hamstrings. And then we have some like other like really good, I think like the medical providers like hit list, right? Like these are the things I see the most commonly in the clinic that frustrate the hell out of me. So please
Yeah,
help. Like that's
yeah, yeah.
always a goal.
Well, I think you've lined up a really great group of people outside of myself, right? And so I'm excited to
Including
hear
yourself, please.
I'm excited to hear everybody talk as well, and really looking forward to it.
It'll be great. It'll be great. I can't wait. But for now, thank you for this quick little digest on the hamstring. And we look forward to I look forward to your lecture too as well. So thank you for everything in advance.
Thank you.